pandemic situation, given the incredible limitations that Patrick's just outlined on health, on water provision, on sanitation? How are they managing?
Thank you so much, Mr. Andrea. Yeah, so in Dadaab, I used to stay in Kakuma and then moved to Dadaab, but I'm currently in Nairobi for educational purpose. So I will start with all schools, the fact that everywhere around the world, the schools are closed. So the same thing to Dadaab. So all schools are closed, and most of the learners are facing the challenge for online learning, which they are used to classroom. So it's a bit challenging. And the other thing is the business have declined because of inflation. For example, we used to buy 1 kg of beans was 100 shilling, but today it's more than that, it's 200 Kenyan shillings. The other challenge that we are having mostly is the social physical contact is much, it's not much being observed because of limited space. Because of limited housing space in the camps. For example, we're having shortage of shelter. Most of the youth are sharing the rooms, which make it hard for obtaining social physical contact. The other thing is increase of teen pregnancy, not only in the camps, both camps, that is Kakuma and Dadaab, but also in nation, across the nation, that is in Kenya. The other thing is increase in crime because youth are idle. They have nothing to do. They're just indoors, and that thing is bringing issues like somebody thinking of like, I don't even know how I'm going to support myself. So they are resulting in stealing. With that one, we have UNHCR and other agencies coming up with how to help us, the refugees in both camps, that is in Kakuma and Dadaab. So the UNHCR has collaborated with Kenyan government to make sure that whoever visits the camp, that is in Dadaab or in Kakuma, should go for a isolation quarantine area for 14 days. And and before being released to the community, they have to go through a thoroughly test that is either you are positive or negative. If you are negative, then you will be released into the camp after that. If you find that you are positive, then they will have to take you to hospital whereby you will be treated. Both host communities and refugees are working together to achieve this. The other thing is humanitarian agencies have set up hand wash and sanitization in the entries of each block and marketplace. And in addition to that, each household is having a sanitation station in their own compound to make sure before you come into their compound, you have to wash your hands. After getting outside of the compound, you have to wash your hands. The shopping place, that is the marketplace, is free. There's that freedom of movement in the camp. You can go to the market and come back. There's no that total lockdown in the camp. But it's only coming in the camp is an issue. But inside the camp, you can go to the market freely and come back. The other thing is the UN and local communication companies have collaborated to make sure the refugee students can gain access to learning online by providing affordable data bundle that is for the tertiary level scholars refugees, that is in higher education of university. And for the primary and the high school, that is the secondary school, the humanitarian agencies have distributed radios and tablets to learners for easy accessing the education program. The radio only works with energy, that is the solar. It doesn't need electricity or battery. It's actually very easy to use. The other thing is the refugees themselves are helping in the fight of COVID-19. Some refugees are helping in the fight of COVID-19, sponsored by, for instance, some sponsored by Albert Einstein German Academic Refugee Initiative are distributing soft masks and food items, not only to refugees, but also to the host community, both in Nairobi, Kakuma, and Dadaab. Thank you so much.
Thank you very much, Adhieu. We can take some questions now, and I think we can go live to Cara Anna from the Associated Press in South Africa.
Hi, can you hear me okay?
We can hear you.
Hi, thank you for this. Dr. Somse, when you say the global platform for supplies is not functioning, Can you explain what you mean by that and give more details? And a second question is for any of you. What are the most striking examples of stigma you've encountered, and how is that challenging your work in this pandemic? Thanks.
Minister, can we just turn to you for the first question?
Yeah. As I said, I don't know how it is for other countries, but first, we were not in the list of priority countries, and so this has resulted in us not being completely overlooked in the the chance for access to possibility for purchasing good. The second one is we have through WHO all the supplies, all the equipment and tests, and we are still waiting. We are waiting because I believe that this is due to global competition, which is well known, which we can't understand. We can't understand because we keep hearing on the radio that, for example, in the UK, or in a similar country, you have around thousands of millions of tests being conducted every day. But here we are dealing with hundred of tests, barely 200 tests every day, and we are in a scarcity, misery of tests. We have to rely on Chinese donation. Has not been the Chinese donation, we would have not done nothing at all. We would not have known even where we are in the epidemic, how much cases we have, if the virus is circulating or not. So this is what I mean. This is what I mean, and I believe that this is a big ethical issue, a big inequality crisis, which point to the discrepancy between speech and talk and the reality, as it pertains to our case here.
Thank you, Minister.
I did not understand well the question on stigma.
I think that question.
A second question.
Yeah, I think that question, I'm going to turn to Adhieu perhaps to answer that question. Really, I think talking about any examples of stigma that you've faced in or that you've encountered during this pandemic.
Thank you so much. Refugees naturally are people that are traumatized because most of the refugees flees home because of war. So the most recent situation that stigmatized me or other refugees is the hearing of COVID-19, and that actually it's in the camp, and some of our people, the people I know, have contracted the disease. It was really traumatizing because we just felt like there's no tomorrow. It's like the end of us. But at the end of the day, we find out that the UNHCR and other humanitarian agencies are working together for our own protection. They're protecting us, and us also being involved in the decision making and also doing their sanitization in the blog and all this. It really calmed us down. But that was the most traumatizing situation ever.
Mm.
Thank you.
Thank you, Adhieu. Can we go to Irene Ubani in Nigeria for her question?
Thank you very much. With respect to all that has been said regarding global solidarity, I would like to find out what are the areas of humanitarian responses for which the World Health Organization has discovered that if expanded in scale would help healthcare workers particularly, so that organizations can start to channel all of their focus, all of their energies within these areas. Thank you.
Thank you. Dr. Moeti, perhaps we can turn to you for that question.
Yes, thank you very much. I mean, first, let me just point out we're having huge problems with connectivity in Brazzaville and missing some of the conversations. I hope our connectivity will be stable for a while. You know, in WHO, we're putting communities very much at the center of our response strategy to COVID-19. And so it's important that response strategies of member states supported by WHO and other partners take into consideration the health needs of communities and adapt accordingly planned actions. So we're working very much within the UN in the definition of the actions that have to be taken in the humanitarian space, and really trying to urge that link between the humanitarian work in health and the needs of the pandemic and among the populations that are affected. So some of the adaptations that I mentioned earlier, and I very much liked the ideas and the innovations that the minister talked about, that instead of, in a way, taking a realistic view of the possibilities of some of the interventions, let's rather try to focus on those people who are most vulnerable to the bad outcomes and put our efforts there in ensuring that those outcomes don't come about. We work very much with humanitarian partners in an ongoing way in countries where the situation is bad, like in the CAR, in South Sudan, in parts of Ethiopia. So what we are doing is making sure that we adapt part of what we've been doing on an ongoing basis to the context of the COVID-19 response, and especially to make sure that those basic services that the minister was alluding to, so for people with chronic diseases, for other infectious diseases, for immunization, are also taken into account as we work with the health systems, with the health workers of our partner agencies, to make sure that services are available for people.
Thanks, Dr. Moeti, and thanks for bearing with us, everyone, through those connectivity issues. I know it's not easy in Brazzaville to catch everything and also online. I want to go to David Andelman, if we can, from CNN Opinion. David, do we have you on the line?
Yes, thank you. How much of Africa's comparatively restrained numbers on COVID-19 compared to other parts of the world is due to the lack of testing and is simply concealing far deeper problems that could help reseed other parts of the world this fall or winter?
I think, Minister, you touched on the difficulties that you have in testing large numbers of people. Perhaps I can turn to you first for an answer to David's question. And he's asking, is that lack of testing hiding a much bigger public health problem? What's your perspective? Dr. Somse.
Yes. Can you hear me?
We can hear you. Thank you.
Yes. Yes, we suspect that it's hiding a major public health problem, because we cannot really have the real situation throughout the country. We have an indication based on the small possibility of testing that we have, because we have been using the test very strategically. But I think the question remains through our strategic approach that we need to take care of those most vulnerable, because what matters the most in this epidemic. What matters the most is that we avoid high mortality and impact, human impact and economic impact. And in a country like Central African Republic, which a country which is highly vulnerable, highly fragile, economically, politically, security-wise, it is almost the whole population that is vulnerable. And among them, those who are the most vulnerable, having those comorbidities and those diseases. So if you could have a possibility for testing them, at least testing half of the population, which is the third of what the amount of testing done in the UK, or I don't know how many million it is being done now in the US. We would be able to really contain the epidemic. So yes, this is a real hindrance to a response, to our response.
Thank you, Minister. Dr. Moeti, given the constraints that we've heard of from Minister Somse on testing, how concerned are you at the WHO that we're really missing out on the vast extent of this potential problem? Just checking. You're on mute, I think, Dr. Moeti. Okay.
Okay.
Yep.
Yes, thank you. Our connectivity really is problematic. I just want to check that you can hear me.
We can hear you, thank you. And I don't know if you caught the question there, which was about, is the lack of testing hiding a much bigger problem across Africa? The minister talked about his problems with testing large numbers of people.
Yeah. Yes, I mean, I think there's no doubt that the lack of testing kits is particularly in some of the low-income countries that are very much dependent on international support for procurement, but increasingly, although in other countries who can afford to pay but don't have access to the supplies, there is some degree of underestimation of the cases because the testing then is limited to those who are exhibiting symptoms in most of the countries, who are coming to a health facility. There's been some attempt in some of the other countries to try and promote early testing, people who have been contacts of others to come forward themselves and be tested. No doubt that there is an underestimation. But we've seen that in some of the countries that have managed to increase their testing capacity, it's not in all countries that you get then a commensurate increase in the proportion of tests that come back positive. So there's a diversity of in the situation. There are countries where the more you test, the more you find in terms of some of the percentages coming back positive being up to sometimes 10, 8%. In many of the countries, say in Senegal, for example, when Senegal produced their own test kit and then expanded significantly their testing, the proportion of those who were positive did not go up. So it meant that the testing wasn't uncovering hidden cases. I think that it is a mixed situation. There is a certain degree of underestimation. We've had waves as well in the capacity for testing. At a certain point in time, WHO and working with the Africa CDC and the Jack Ma Foundation were able to get some tests into countries. And here we saw an increase across the board. So I would say there is some underestimation. I don't think, though, that we have a massively underestimated situation where thousands of people may be sick, dying undetected from this virus in African countries. And I very much agree with Mr. Somse that in this situation, that it's best to target strategically so that you prevent mortality. And then the more we are getting these rapid tests, we are suggesting that those should be.
Dr. Moeti, we lost you there for a moment. We'll try and get the connection with Brazzaville back up and running. In the meantime, can we go to Mike Mwaniki from Kenya Media Services? Don't know if we can get Mike up live. He's in Nairobi in Kenya. Just going to see if we can. So we can see Mike, but we can't hear him. Perhaps we can hear you now. Mike, your question. No, we're still struggling. We're having a real connectivity day today. Mike's question is, how many cases of COVID deaths have been reported at Dadaab refugee camp, and how are camp officials ensuring physical distancing is being observed, bearing in mind the levels of congestion in the camp? Maybe I can hear from Patrick Youssef on that. Patrick, how do you manage to get any kind of physical distancing in conditions in camps like Dadaab, and how do you protect both refugees and people working in camps?
Sure. I think there is no simple answer. When we see 10 families living under one tent, it's just simply impossible to apply certain norms that we can easily see happening to different levels of success in other environments. So the first and initial response is indeed enabling the displaced, the host communities, all those around displacement camps to have access critical for information. So information is considered as aid. And that was done indeed with the support of the myriad and the number of Red Cross and Red Crescent volunteers, even in the most remote areas. I would say also that there has been infection control measures that were put in place in these camps, where we had distribution of hygiene kits and other forms of assistance to enable those people living in these places to get the proper preventive measures right. And I would say the third is adapting our food assistance, because that hasn't stopped, or any other form of assistance, to respect these preventive measures. So meaning including during distributions of food assistance or water supplies, etc., that these measures are being respected. But I would say again that for many, these measures have been implemented. Some cases maybe have occurred, but we don't know all the truth. And it's true that as Dr. Moeti has mentioned, we don't own all the truth, but we do try to do, even in places of detention, as those ferry boats where one case, when one case is detected, the whole boat is basically infected. In these places where physical distancing is impossible, information has been considered as a major vector, passing on the information in local languages as we did, in local languages with local radios, in order to create proximity, and most importantly, learn from other crises that we had to live through in Liberia or in the DRC, related, for example, to the Ebola crisis.
Thanks for that. Just very quickly before going to Adhieu, I just want to take Kevin Kelly from the Nation Media Group in Kenya. Kevin, can we just get your question in?
Yeah, are you able to hear me?
Yeah.
Okay, great. So thanks. My question was similar to the one just asked about the extent of the cases in Dadaab. I'd like to ask the refugee woman herself, to what extent is the UN being forthcoming with reporting on the infections and the death rate in Dadaab? The last I saw, which is about a month ago now, the UN was saying there were 9 cases in Dadaab, which seems kind of low given the situation in Kenya and throughout Africa generally. Do you have any information on that? Thanks.
We'll ask Adhieu. Thanks for that. Adhieu, can we just turn to you? And I mean, obviously you're in Nairobi now, but anecdotally perhaps, what are your experiences talking to people who are still in Dadaab and maybe in Kakuma?
Yes, thank you so much. I'm communicating, actually do communicate with those in Kakuma and those in Dadaab. Yes, I have a family in Dadaab, so actually we all know what is happening in Dadaab and in Kakuma. And yes, it has been reported that in Dadaab we had 9 people. These are people who are coming in from Somali. They were put in a quarantine for 14 days, isolated area. And after some time, they have to go to test before they were released to the community. And at the end of the day, they were positive. It was too fast, and then the rest joined in with the positive results. So they were put into a quarantine place, isolated place for medication. And so far, so good, everything is fine. They have recovered, and we don't even have any case at the moment in Dadaab. The same thing to Kakuma. The people that the case we had in Kakuma, these are the new arrivals who are coming from the other part of Somali, going into Kakuma. They're also put in quarantine for 14 days, isolated place. So when they tested positive, they were taken to hospital, and so far, 2 have recovered and they have been released to the community. So I think the medical facilities, being a UNHCR and the UN and the Kenyan government collaborating together with the refugees as well, it's actually bringing a very positive image to the community and also to the humanitarian agents. So I can just in all that everything is fine, everything is being catered for. Thank you.
Thanks very much. Et pour nos auditeurs francophones, est-ce que c'est possible que Dr Yao nous donne une sommaire en français avec les développements nouvelles? Excusez-moi pour mon français.
Merci beaucoup. Le français, il est parfait. Aujourd'hui, nous faisons référence à la situation au sein des populations déplacées, notamment dans un contexte humanitaire. Et dans cette situation, évidemment, l'aspect de Covid constitue un enjeu majeur. Et des populations qui vivent dans une certaine promiscuité, ce qui rend difficile les mesures de distanciation physique et les mesures de prévention. Et donc, cela exige une approche particulière, notamment l'augmentation de l'appui sur certaines mesures comme le point de lavage de main, l'accès à l'eau potable et possiblement aussi la distribution de certains intrants comme les savons et si possible des intrants comme les masques. Cela a été fait par une agence sœur IOM au niveau du Kenya. Il y a aussi que le Covid limite l'accès à certains services de base et donc cela exige aussi une certaine mobilisation pour qu'on puisse continuer à avoir accès à des services de base comme le traitement, par exemple, de certaines maladies, comme aussi des services de vaccination. Et donc, ce sont tous ces aspects-là pour lesquels une mobilisation est nécessaire. Au niveau de l'Afrique, on a une augmentation de cas. On a dépassé les 600 000 cas, les 13 000 décès. Et donc, il y a une certaine variété au niveau des pays. Et pour ces pays-là, certains pays ont un accès limité à des intrants comme des intrants de laboratoire, comme Monsieur le ministre de la Centrafrique l'a évoqué. Et ceci exige aussi une certaine mobilisation et solidarité. Et l'OMS travaille avec certains partenaires pour répondre à ces besoins critiques. Voilà comment on peut résumer le débat qui a eu lieu depuis le début. À vous.
Merci beaucoup. I want to turn now, if I can, to Takashi Ishihara from the Asahi Shimbun of Japan. Mr. Ishihara, can we turn to you for your question?
Thank you so much for everyone. My question is, under the current situation of coronavirus, I believe the refugee or IDP camps are one of the most difficult places to prevent the infection of coronavirus. And I hear like some NGOs or international organizations are getting more difficult just for going to the camps or field or just going to approach the refugees. So in that situation, how has the international organization like UN, NGO, or International Red Cross has changed the way of approach or operation and support for them after the outbreak of coronavirus? Is there any breakthrough for them?
Thanks for that. And perhaps we can get the perspective from Patrick in Geneva with the ICRC, and then perhaps also hear from the minister about how governments on the ground are able to work with some of those NGOs. Patrick.
So, containing the virus is certainly the most complex issue we have to deal with since years. And containing the virus and trying to create a cordon around those locations, the displacement camps and prisons, again, those are the two most prominent places where we would want to avoid at all costs the spread. So again, we really had to adapt our ways of working. I would also want to insist on the impartiality of humanitarian action and trying to get as much as possible to have a dialogue with all armed actors on the ground, where when we speak about internal displacement, we speak about a war, we speak about warring parties, mostly non-state armed groups with whom the ICRC, with which the ICRC wants to continue having a dialogue to get access not only to the camps close to the capital, but also to the most remote places where COVID and the notion of COVID and the definition of COVID is honestly not even known, and where the humanitarian needs have been on the increase. And if I can use this opportunity to say that as much as humanitarian actors are giving that space to get access to these places and make sure that preventive measures are also spread, can help the delivery of humanitarian services. But we have also to say that we need to work with local actors, with the sheikhs, with the religious circles, in order to get that message across. In some occasions, as my colleague from Dadaab has mentioned, there were some cases of stigmatization that we had to work through and work around, including with local actors, which brought us into a different notion of proximity with those who can help us, meaning the communities who can help us deliver these services while protecting ourselves. And we shouldn't forget the duty of care that we owe ourselves and our teams and our volunteers on the ground.
I would like to go to the Minister in a moment, but can we just turn to Erin Baker from Time Magazine in South Africa for her question? Erin.
Thank you very much. We've been discussing some of the inequities when it comes to access to testing, prevention, and treatment here in Africa. Are there concerns that the same inequities will be perpetuated when it comes to the distribution of a potential vaccine? And how should African nations and health leaders address this issue?
Thanks for that. In a moment, I'll turn to Dr. Moeti, but perhaps we can turn first to Minister Somse, because Minister, you've been talking about the difficulties your country has been having in getting kits, in getting equipment, in getting resources. When it comes to a potential vaccine, how concerned are you that the Central African Republic needs to be included in the first list of those able to access it?
No, we are fundamentally concerned. I was part of those who issued a petition declaration in order to require equality in access to vaccine. And, we have just signed a request, to indicate our willingness to be part of those who would benefit from the vaccine as soon as it is available. But the situation in accessing basic supply, basic good, is a source of concern. So we don't know how this will be different for vaccine. So it's a real question. It's a real question that is raised. I would like to take this opportunity to also tell you that our experience in terms of addressing the issue of in the refugee camps or displaced camp, humanitarian actors are doing a good job in our country. They are providing those camps with water, with tent for isolation of cases. But the challenge is that one, denial is there, and people and culture, people don't accept to be separated from the community, to live in isolation in a tent. At the same time, external actors are stigmatized because, as you know, initially the disease is considered as being brought by Westerners, by people from abroad. So humanitarians are stigmatized for that. So what we do is that we are de-dramatizing the disease, because I think what has happened also is that the TV and the news and the way the issue were presented from outside has really create more panic than it should be. And what we are trying to do here, coping with our situation, maybe it is the situation that cause us to be more pragmatic. When someone is detected, the person can remain. If it is a very mild case, the person can remain among the family in the same house wear mask but take precaution to stay aside, and it works. We don't see full-blown, we don't see contamination across the family. So in those camps where people are packed, it is, and people are afraid. You cannot take someone outside the community, which is already scared, and put the person outside. The person, it raises suspicion. So I think, from the government perspective, from my perspective, I think we have to de-dramatize. We have to simplify. This disease is not so highly contagious as we think. People can have infection, wear masks, be, just observe self-distanciation from the family with some education and psychological support. It should work.
Thanks for that. Thanks, Minister. We've had 3 encouraging but very early breakthroughs in the vaccine process this week. Dr. Moeti, I want to go to you to close today's briefing in just a moment, if I may, and perhaps you can comment on that question regarding the provision of vaccines globally. But I want to turn, if I can, to the last question to Marian Isa from FinWeek in South Africa. Marian.
Thank you very much for taking my question. It's for Dr. Moeti. South Africa has the highest number of recorded infections on the continent. We broke the 300,000 mark today, and we're recording more than 10,000 new infections a day. However, our fatality rate, thankfully, has been much lower than the global average. It's been about 1.5% so far. And I wondered, in that case, the early fatality projections that we got here would have been considerably overestimated. I wonder whether the WHO has more up-to-date projections. The related question is,
Thanks for that. We're down to our last 2 minutes of the briefing. So if I can, I'll just give Dr. Moeti a chance to come in on that question, and also perhaps to close on the equal provision of vaccines across Africa. Dr. Moeti.
No. Okay. I mean, I think that South Africa's health system, compared to many countries, does have the capability of providing care for people in terms of outcomes and the case fatality rate. So, and South Africa has been able immediately to leverage the capacity of the private sector as well as the use in the public sector. So we've seen the fatality rates that are not as high. No, in terms of projections, we have not updated our projections for South Africa, and I know that the government as well is working on this. I've heard Slim and even the minister saying, well, they're hesitating to put numbers to things, but they think that it's going to peak around September. I've not looked at the numbers at which they think they will peak, so this is something that we will work on, but it's clearly a very serious situation, which is essentially driving the pandemic in the region at the moment. So it's more than half of the cases that we're seeing in Africa. As far as vaccine access is concerned, I think this is a concern. This is a concern for us as well as for African governments and as well for partners. So there are certain actions being taken. Gavi, working with other international partners and WHO, has devised a means of trying to, if you like, pull countries' capacities together to secure some of the supply. Clearly, Gavi is going to be in its usual way supporting the Gavi-supported low-income countries in order to then shape, if you like, a market for access to vaccines, to the vaccine for the countries they're supporting. They've also contacted middle-income countries that are not supported by Gavi directly in terms of financing and asked them to indicate an interest and to start to, if you like, make a contribution so that the financing for procuring the vaccine of the future can be joined between Gavi for low-income countries and middle-income countries having indicated an interest. It's going to be difficult, I think. Let's acknowledge it. And here, again, is our plea, I'll join the minister, for global solidarity. This is one area where we really will need global solidarity in action by those countries that have the capacity to capture the supplies because they have the funding to do so.
Dr. Moeti, thank you very much. We've come to the end of today's briefing. A big thank you to Minister Somse for joining from the Central African Republic and providing a very pertinent update on the reality of the situation that he and his country are experiencing. A big thank you too to Adhieu Achuil Dhieu Kueth for joining from Nairobi, Kenya, and providing a perspective from refugee background. To Patrick Youssef in Geneva from the ICRC, a big thank you. Thanks most of all to Drs. Moeti and Yao for battling connectivity to stay with us for the full hour. Thanks to everyone for joining. From all of us on the call, have a good rest of your day and look forward to seeing you at future briefings. Thank you.